School of Medicine, New York, USA. Dr. Shabsigh received his medical degree from Damascus University Medical School and did 2 urology residency in Germany and the USA. He completed a residency in urology and a fellowship in sexual medicine, urinary incontinence, and urological prosthesis at Weill College of Medicine in Houston, USA. And Dr. Shabsigh is a fellow of the American College of Surgeons, a diplomat of the American Board of Urology, an active member of several professional societies. He's also the past president of the International Society of Men's Health and the editor-in-chief of the Journal of Men's Health. Currently, he wrote a book about the health crisis management in acute care hospital, lessons learned from COVID-19 and beyond, which was published in March 2022 in both papers as an e-book by Springer Nature. So Dr. Ridwan Shabsigh.
Good morning, everyone, and congratulations for the wonderful annual meeting in this beautiful city of San Antonio. So I would like to share with you over the next few minutes the experience that we lived through during the COVID crisis in 2020. So here we are in a, sorry, let me just start the presentation. Okay. So here we are in 2020. And if you recall, in early 2020, news was coming from China, and then shortly thereafter from northern Italy. If you remember from northern Italy, horrific news about overwhelming number of patients with respiratory distress coming to hospitals. So I picked up the phone and I called my friends in northern Italy. I called my friends in San Raffaele Hospital in Milano. And I spoke with them and I heard the news. Large numbers of patients with respiratory distress coming to hospitals at once. And hospitals mobilizing the ICUs, stopping all elective surgery, stopping all elective admissions, and mobilizing all the resources, unable to keep up with the care needed for such patients. So that's the first thing I learned from my friends in northern Italy. I did not have a chance to speak with anyone in China. So the other thing I learned that loss of physicians and nurses and others to COVID itself, that this is not a disaster such as an earthquake or a flood. This is an infective disaster that not only brings you a lot of patients, it can take away your resources. So that what actually triggered my thinking. So I was thinking, and I really expected that this is coming to us in the United States. And out of all the United States, I said, we in New York, we will be hit hard. We are like the portal of the country. And we will take this on. And we are a small community hospital in the Bronx, where people have a lot of socioeconomic challenges. The socioeconomic determinants of health are in bad situation. A lot of people live in small apartments, overcrowded, poverty is prevalent. So a pandemic would spread very, very quickly and become, How do I pronounce?
Arrow down.
Arrow down? It's not the hand. Oh, now it's working. Yes. So I concluded several conclusions. One, that we will be hit very hard. Two, that elective work will stop. Three, that our resources will not be enough. Four, I'm the chairman of surgery. I have 16 surgical specialties under my administrative responsibility. And what am I going to do with my surgeons? I have breast surgeons, I have bariatric surgeons, plastic surgeons, urologists. Okay, am I going to furlough them? I concluded that expected that the Department of Surgery, remember, COVID is not a surgical disease. We don't treat it with scalpel and robot. We treat COVID is a medical disease. So I predicted that the Department of Medicine is not going to be enough. So what am I going to do as the chair of surgery? Just watch this happen, go home, say, okay, elective surgery is over, and wait until the pandemic is over and then come back. So in early March, and this timeline is very important, I decided to throw my department in the front line. So I went to the senior administration and I said, we, the Department of Surgery, we're going to serve in the front line. And I explained that, during a crisis, no hospital lends hospital a hand. Everybody is overwhelmed. I predicted that during the pandemic, there would be nobody giving us, critical care physicians. There will be no locum. It's going to be a rush to resources. So with that, we proposed cross-training of non-critical care surgeons and other physicians in critical care to serve for the coming wave of critically ill patients. Initially, people thought that was crazy. How are you going to take a bariatric surgeon who has been doing bariatric surgery for the past 12 years and put him in the ICU? Would you like to be, cared for in the ICU by a plastic surgeon, by a breast surgeon? How is that going to happen? So with that, with this upcoming, surge, this is the surge of cases with positive COVID and need for ventilated ICU care. With this kind of surge, we had no choice but to do it, but we wanted to do it in an organized fashion and to do it safely. So we created a program of cross-training and deployment. The cross-training, it included education, theoretical education. It included training with existing critical care surgeons, critical care physicians and intensivists, and then frontline deployment under supervision and support. We did not just throw the colorectal surgeon and the bariatric surgeon and the plastic surgeon in the ICU. We provided also another layer of support and supervision. So there was a self-study, and we used the Society of Critical Care Medicine curriculum. They had a curriculum for training which included multiple modules. We had an intensive program of these didactic sessions. It was done daily, and that happened after the governor of New York issued the order to shut down all elective surgery. All elective surgery was shut down on March 16. I still remember the day when we received the order. So after that, we started training on March 24th. Just 8 days after the governor order, we started training the physicians, the non-critical care physicians, including multiple surgeons that we had available at that time. This is the combination of self-study schedule followed by didactic sessions. So you study a module. These are the different modules of the Society for Critical Care Medicine. You can see the modules on the left side, and then the next day we in group discuss that module with senior critical care and intensive care physicians. And a total of 17 non-critical care physicians completed the program. Those were successfully then deployed to a 12-bed ventilated unit. A 12-bed ICU was staffed by this group. And this came very handy because this came in April. Now we are into the pandemic, into the height of the pandemic. The height of the pandemic was on, for us in our hospital on April 6th. On April 6th, we had 95 patients on ventilators in the ICUs. On that day, a couple of weeks later, we deployed our non-critical care physicians to take over a whole ICU unit. At that time, the existing resources of intensivists were burnt out, were tired. Some of them had COVID themselves and had to be sent home. And there were this group of non-critical care physicians served in the ICU for 5 weeks with no major incidents. They lost some patients, they extubated some patients went home. It's an amazing experience. We provided supervision of this and support for this group. For our good luck, we had a senior cardiothoracic surgeon. So if you recall, cardiothoracic surgeons in old days, they recovered their patients themselves. They were the critical care. They did surgery and critical care from their own surgery. So they ran their own ICU for that. So that was a really dear resource. And that physician provided the senior supervision and support by tele-ICU rounding daily on an iPad on wheels. We had an iPad on wheels with connection from home, and we ran a checklist on all patients. We rounded, they were rounding in the ICU 3 times a day. This is a picture during the pandemic, and this picture is very, very dear to me. It shows here myself. This is myself. This is Dr. Porcino. He is a colorectal surgeon. This is Dr. Peterson. He is a breast surgeon. This is the general surgery chief resident, and this is the IT support person. This is Dr. Lafaro, our cardiothoracic surgeon, in the iPad. This is the iPad on wheels, the tele-ICU. This is rounding in the ICU on critically ill patients with ARDS, with a colorectal surgeon, breast surgeon. This is after the cross-training that and the deployment. We did provide a predefined set of privileges. Those were temporary privileges for critical care to these surgeons, and those were terminated after the pandemic. We did provide also malpractice coverage for this period of coverage. From the administrative viewpoint, this was covered from all sides. Another thing that happened, we have a good group of orthopedists, orthopedic surgeons, orthopedic trauma. We had elective orthopedic. We had also orthopedic physician assistants. So with the reduction in trauma, during the pandemic, and and also with the cancellation of elective surgery, we thought that the best thing for orthopedics, that's what they do. They position patients on fracture tables. They are excellent in that. They never have an accident in, loss of airway. So we created the proning team. The proning team, we repurposed our orthopedics. So every day we had a proning supining list, and the orthopedic team picked up the list in the morning and ran throughout the ICUs in the hospital, tens of patients, prone them safely and return them to supine safely. This is a demonstration that we did. This is a picture from our book that Dr. Nazir mentioned on health crisis management in acute care hospitals. Shows the orthopedic team, again, surgeons and PAs training. This was, I can tell you, the other thing that happened here is the senior administration, the executives of the hospital were super impressed that the Department of Surgery participated in such a strong way, and the department gained tremendous respect after this big involvement. So, following the pandemic, we did a refreshment of these skills because we thought such a workforce is a tremendous asset. The Greater New York Hospital Association endorsed this cross-training program, and that became also important in the second wave of the pandemic. So I think cross-training of non-critical care physicians and surgeons specifically is very feasible. It can be done safely. It can be deployed safely. And I think this can be a valuable resource in health crisis, especially infective health crisis such as a viral health crisis like this, and tele-ICU, among other things, also can provide fantastic help during health crisis. I hope I was able to share with you this experience from the COVID-19, and I thank you very much for your attention.
Thank you very much, sir. He's the chief of trauma at Bronx University.
Nice presentation. I think, a lot of us who were in New York at that time underwent something similar. They say that necessity is the mother of invention, and clearly you had to put together what you had to put together for, especially for those people who weren't really doing their routine work, their routine operating. What do you say about the pushback for out of sight, out of mind? I mean, you talk about operational readiness, and I'd love to hear anybody from the military, that when we are not in a wartime crisis, it's hard to maintain or sustain that readiness. The further we are away from time zero, from COVID, the more people lose enthusiasm and interest to say, this got the 6-month retention program. How do you plan on convincing your hospital that this is actually important? Or do you think, now that you have a playbook, we probably don't need to have any sort of retention process in place, and God forbid you see the blip of another pandemic on the horizon, we would then go to our playbook and mobilize resources at that time. Thanks for your presentation.
Thank you. So in terms of no hospital overhires, and in today's health economics, there is no redundancy in anything. So everything is very, very tight. And I think that goes for big medical centers as well as small medical centers. Now, small medical centers are more challenged. Like our center, we are very, very tight in terms of budget. The majority of our payer mix is Medicaid, so Medicaid budgets are well known. But I think maintaining, two things I can say, maintaining operational readiness is one thing. The other thing is maintaining the collaborative culture. So you mentioned the pushback. I can tell you, when this happened, no surgeon, although they were very nervous, a breast surgeon who had been doing breast surgery for the past 20 years, a urologist who has been doing urology for 30 years, to say you're going to manage the ICU, they were very, very nervous, and rightfully so. But no one pushed back. No one said, I'm not going to do it.
Barry Anderson from Ann Arbor, Michigan. So I had worked at a 537-bed level 1 trauma center, and obviously we were sort of hit hard in Ann Arbor, although Ann Arbor probably is a little bit of a younger population because of the university there. But nearby, one of our neighboring hospitals, part of our hospital system, Livonia, Michigan, had a much higher elderly population, and they were struggling, and they were really just outside of Detroit. They were hit pretty hard. So it was interesting because there were 7 of us trauma surgeons at the level 1 trauma center, and I volunteered to go over to Livonia, the smaller, kind of hard-hit hospital, to help out. So of my 7 colleagues, only 2 of us volunteered, whereas the other 5 declined for various reasons. One had 6 kids. He didn't want to be exposed to COVID and work in the ICU there. One of them was recently married. He didn't want to go. And it was really interesting that, and I was 62. I was the oldest of all of them. So as I thought, you know,
I protest that. 62 is young.
well, I'm with that. But I was the oldest of all 7, and I was the one that went over with one of my colleagues. But it was just interesting, you know, the disinterest in helping out one's community, even though it was 20 minutes away from our level 1 trauma center. That, you know, there was that kind of pushback from my colleague. That was most of the people who pushed back.
I think cultivating, you know, you have these hard skills and the soft skills. Cultivating a collaborative workforce during peacetime, you don't see the value of it, you see the value. I joke with my friends, I say, you know your friend on a bad day, you don't know your friends on a good day. Thank you very much.
We'll move to the next speaker. We have Dr. Lauren Harris. He's the chair of surgery at Richmond University Medical Center, Staten Island, New York, and also chief of thoracic trauma, thoracic surgery, Dr. Lauren Harris.
Can you all hear me? Okay. Well, thank you to Dr. Nazir for inviting me again. Last year I gave a talk on tracheobronchial injuries, which are kind of the centralized version of the injuries we're going to talk about today. But this should be basically a review for any thoracic surgeon, and certainly trauma surgeons in the room. Most trauma surgeons are thoracic surgeons at times. I just wanted to say that was a very interesting and enlightening talk from Dr. Shabsigh. I remember training I began my training in 1987, and in those days, critical care didn't exist. You know, we were the critical care doctors for our surgical patients, and I learned most of my critical care from the nurses. Because they learned from the more senior doctors, and when I came to the bedside, they would say, "Put them on this." Okay, good idea. And we learned through experience and reading and other people's experiences, and I think that a lot of this represents who doctors are in general. You know, the doctors were the only ones going to Bellevue Hospital during the typhoid outbreaks in the 19th century. Because that's what they did, and many of them died from typhus because, of course, they didn't understand what it was and how to treat it. But they were there taking care of those patients, and I think that's a lot of what we saw in terms of surgeons who don't do critical care on a daily basis, kind of getting back on the horse. It's kind of like riding a bicycle, and a lot of them, once they got caught up a little bit on their critical care specifics, were able to do it quite well. And my surgical residents and my surgical physicians at my hospital essentially did the same thing. They volunteered to go and join the medical teams to help on the floors and in the ICUs, because that's what we did. That's what physicians do every day. And I was very proud of them, and that's quite an achievement on your part. And I always tell my surgical residents that surgeons are internists who have actually gone on to finish their training. So And I think that that's very true. And I'm married to a pulmonologist, so I don't say that in front of her, but I think it's very important that that's who we are. When there are sick patients who need help, that's what we do. And we step up. And even if we don't understand the disease, like we did not understand this disease in the early months of 2020, we're still there doing our very best to figure it out and help sick patients. So that was a great kind of reinforcement of my opinions already about who we are and what we do. So thank you for that. So having said that, I'm going to go on to talk about penetrating thoracic injuries. And like I said, most of you are trauma surgeons and thoracic surgeons, so this is, for the most part, should be a review of this topic. I don't have anything to disclose. We're going to basically go over some basic anatomy, because the external anatomy in the chest is fairly simple for those of us who've been there. And basically what I'm going to deal with are the two most important or two most common types of penetrating injuries of the chest, which include pneumothorax and hemothorax. We'll talk a little bit about the work of an evaluation and the treatment strategies. And again, most of this should be a review for most of us. Well, chest injuries have been talked about and written about for thousands of years. The Greeks wrote about it in terms of anatomy. Galen and some of the other great physicians of their time mostly knew about it based on war injuries, because that's the only time that they actually saw the anatomy. In those days, doing a necropsy was against the law, and you couldn't do it. So there was very little knowledge of anatomy, and certainly less of physiology. But with the help of Ambrose Paré, John Hunter, Jean-Dominique Larrey, during the 17th, 18th, and 19th centuries, our knowledge base began to build significantly. So we know that the vast majority of thoracic trauma can be managed non-operatively. That's great for me. I'm a thoracic surgeon. I love that fact. That's one of my favorite facts, because most of the time when they call me from the trauma bay at night, I can say, well, put a tube in and we'll reassess the patient in the morning. Perfect. Right? So that's the great thing about thoracic surgery. There are very few surgical thoracic emergencies, with a couple of exceptions. So from the trauma standpoint, the lungs are very resilient organs. So, and now with the development of minimally invasive techniques and better critical care and anesthetic techniques, most of the thoracic trauma injuries that require surgery can be done so minimally invasively and with minimal discomfort to the patient. The anatomy we all know very well, the bony anatomy of the chest, and I talked last year about more centrally located injuries, but these things have to be kept in mind anytime you're dealing with a penetrating injury to the chest. And you also have to remember that any penetrating injury below the nipples or below the fourth intercostal space is actually an intra-abdominal injury until proven otherwise. And that's because of the movement of the diaphragm. So you have to be very, very wary of that. So the true incidence of penetrating injuries of the chest are unknown. There are multiple reports out there about it, but most of the time it's very hard to tell what percentage of penetrating injuries are involved in the chest. Most of the deaths from penetrating injuries to the chest occur in the hospital, and that's just a function of better EMS, better care in the field. These patients come in who would have otherwise died in the field years back. And in the military reports, up to about 16% of military penetrating injuries involve the chest. So gunshot wounds, up to about 80% of those require surgical intervention. And you see reports of gunshot wounds to the abdomen being treated expectantly in patients who are hemodynamically stable. I think that's a little on the edge for me, but there are some successes being reported now with doing that But for the most part, even gunshot wounds to the chest for up to 20% will not require surgery. And of course, with stab wounds to the chest, again, about up to two-thirds of them may require surgical intervention. But again, it's not the knife injuries and other types of non-gunshot wound penetrating injuries are much less lethal for the most part. The American Association for the Surgery of Trauma, of course, has a grading system for injuries. Most of us don't really go by this, but it makes sense based on the type of injury and the site of injury. So the workup is the same workup we do on every trauma patient, A, B, C, D, E. Obviously, the physical exam, the mechanism of the wound, so things like subcutaneous emphysema, shortness of breath, deviation of the trachea. I'm still not a big fan of listening for breath sounds in the trauma bay. I can't even hear myself think most of the time in the trauma bay. It's going to be hard to imagine that you can put a stethoscope in someone's chest and hear whispering hectoriliquy. So it's, they talk about it, but for the most part, for patients who have penetrating injuries to the chest, listening to the chest may or may not be that helpful for you. And most of the time, we rely on imaging. We do have the focused assessment or the FAST exam that most of us can do rather well. Many of us are not that facile in looking at the lung on FAST, and we're most of the time looking at the pericardium and trying to make sure we don't have an injury to the heart. But you can see pneumothorax and hemothorax using the FAST exam. Of course, the chest X-ray, which is the thoracic surgeon. I tell my residents that thoracic surgeons live and die by the chest X-ray. Chest CT is great, but for the most part, if you're a thoracic surgeon, you really should be an expert at reading the chest X-ray, because that's what I use, and we use them on a daily basis. I've looked at probably hundreds of thousands of chest X-rays, so you get pretty good at it after a while. I mean, it really is very helpful, and you see it right away. You can miss things on the chest X-ray, and you have to be cognizant of that fact. You can't rely on it 100%, but many times it will give you the basics of what you need to know. Of course, again, ultrasound is useful. CT scan, most patients, most trauma centers, most emergency rooms have easy access to CT scans, and the CT scans can give us a lot of extra detail. We know there's a pneumothorax. We just want to see how big it is, if there are any other associated injuries, and what else we need to worry about, i.e. hemothorax and even other injuries as well. So the true incidence of pneumothorax, again, is probably unknown, but 10 to 12% of penetrating injuries will have a pneumothorax, depending on the type of penetrating injury. High velocity missiles, of course, will have a much higher incidence. Generally what happens is that obviously the mechanism is the disruption of the parietal or visceral pleural surfaces with the entry of air into the pleural cavity. Of course, blunt trauma can do this as well, but blunt trauma generally does it through a mechanism of penetrating injury based on broken ribs for the most part. And of course, you have to worry about associated injuries. Most of these injuries don't occur in and of themselves. When there's a traumatic pneumothorax, you have to worry about traumatic hemothorax as well. And anytime a patient develops a tension, obviously that requires immediate intervention. So the diagnosis is many times clinical. The X-ray can be misleading. You can miss X-ray. You can miss pneumothoraces. Some studies show that about 50% of small pneumothoraces, traumatic pneumothoraces, are missed on chest X-ray. It's also been difficult for a lot of people to size pneumothorax, even though I'm of the opinion that most traumatic pneumothoraces, in unless they're very small, only picked up on CT scan and not associated with other injuries. With that exception, almost all traumatic pneumothoraces should be drained. Okay, and mostly because those patients have other injuries and they're going to be going elsewhere in the hospital, and you may not be able to monitor the growth of a pneumothorax adequately, and God forbid they develop a tension pneumothorax somewhere, it could be potentially lethal. But in general, if you have 2.5 centimeters or about 2.5 centimeters from the edge of the lung to the chest wall, that represents about 50% pneumothorax. So that's a good way to size it. There are other more precise ways of sizing it. You can use FAST, and I really believe, as seen at the bottom here, that any patient with even a small pneumothorax or a potential pneumothorax, let's say you don't see a pneumothorax, but there are multiple rib fractures on that side, that patient is going to general anesthesia for something else. I think that those patients should be drained prophylactically, because I've seen instances where the patient's under general anesthesia having something done to the kidney or some other abdominal injury, and the next thing you know, the anesthesiologist is telling you, I don't have a blood pressure. Okay? So I think that for the most part, you can put a small tube in on that side just as a prophylaxis, so that you don't have to worry about the patient developing a tension under positive pressure anesthesia. So we've all seen these types of things before. Again, I am of the opinion that the image on your right, that tension pneumothorax, that chest x-ray should never be taken. You shouldn't ever see that x-ray in your trauma slot, because that is a clinical diagnosis. Okay, but that's what it looks like. Okay, so basically the way to treat these traumatic pneumothoraces, again, I feel that they all should be drained, with the exception of with very small pneumothoraces that are asymptomatic, not associated with other injuries, in a patient who is not going to require general anesthesia, where you can observe the patient and repeat x-rays just to make sure that those pneumothoraces do not grow. And remember, most of the studies show that pneumothoraces that are stable over the first 6 or 8 hours, there's only about a 20% chance that they're going to get bigger. So for the most part, most of those will remain stable. Okay, but oxygen therapy, we all know that oxygen, we're breathing mostly nitrogen now, about 70% nitrogen. And nitrogen is very poorly reabsorbed. So if you can replace the nitrogen in that space with oxygen, that's much more rapidly absorbed. And that's why when we do either robotic or laparoscopic repairs of hiatal hernias, and you get a pneumothorax during that operation, you get into the pleural space. We don't generally drain those at all, because that's CO2, and CO2 is very rapidly absorbed. So by the time you get to recovery, when you do an x-ray, there's no pneumothorax there. So if you can get oxygen, if you can replace that nitrogen in that space with oxygen, it'll absorb quicker. But for the most part, these patients, by the time they're in the trauma slot, the air leaks or the reason for the pneumothorax has resolved. So putting them on 100% oxygen makes the nurses feel good, but for the most part, you're not going to replace the nitrogen in that space very quickly with oxygen. So it's a thought. It's not a great way to treat pneumothorax for the most part. Aspiration is something that, for the most part, we do in spontaneous pneumothoraces. The British Thoracic Society's guidelines for treatment of spontaneous pneumothorax, that is a level 2B recommendation for aspiration instead of putting a tube in. But for traumatic pneumothoraces, it's not really the best way to do it for multiple reasons. Most of these patients have multiple injuries. They're having other issues. The other workups are happening. If there's a space there and that patient's going off to whatever place in the hospital, it's probably best to drain the space. So for the most part, a chest drain is recommended. And for the most part, I don't generally recommend using pigtail catheters, because a lot of times there is blood associated with it. And as we're going to see in a second when we talk about traumatic hemothorax, the initial drainage is very important in determining whether or not these patients have retained hemothorax. So for the most part, I do not use even the larger of the pigtail catheters for this. And for the most part, again, most of these patients do not require surgery. They will not need surgery later on. But if there's a central injury and there's a large air leak in your pleurovac and non-remitting air leak, then surgical VATS is a good way to go. And I would highly recommend, as per my talk last year, that you do bronchoscopy first, because you want to make sure you don't miss something central in that airway that you will not be able to fix with VATS, and that would alter your therapy significantly. So always remember the bronchoscope. So hemothorax can occur with any blunt or penetrating injuries. We do see it very frequently with penetrating injuries, both high and low pressure sources of hemorrhage. You can get hemorrhage from anywhere, from an intercostal artery or intercostal vein to the lung itself, and of course the heart and the great vessels. That will be audible bleeding, if you will. Mediastinal structures, chest wall injuries, all of these can produce a hemothorax. 25% of the hemothoraces will be associated with pneumothorax, so you have a hemopneumothorax, and about 75% will have extrathoracic injuries. That's very important to remember, because again, most of the hemothoraces will not require surgical intervention in the chest, but are much more likely to require surgical intervention somewhere else. So you have to be cognizant of that fact and think of the patient on the whole, not just in terms of the chest injury. Even though the hemothorax can be quite significant and can kind of grab your attention, you still have to be cognizant of those other injuries potentially being present. So of course, working it up, you have to think about the mechanism of injury, the signs and symptoms that the patient presents with, and just remember that even though chest X-ray is an excellent and usually the first imaging that we do, other than a fast of the pericardium, the chest X-ray can hide a fair amount of blood, especially in the supine position. You can hide almost a liter of blood in the chest on a supine X-ray. And remember that for an upright AP film, you can hide about 50 to 100, maybe a little more. But for a PA film, you can hide a little bit less. But for an AP film, which is what you're going to be getting in the trauma bay, and if it's upright, you can hide a lot, 200 to 300 cc's. So that's not an insignificant amount. And of course, chest CT is much more specific in terms of the amount and whether or not there's ongoing extravasation from some source. So that can give you a lot. Of course, this has to do with patients who are hemodynamically stable. You're not going to send an unstable patient to chest CT. All right, so again, we've all seen these X-rays and the ultrasound and the CT scans with hemothorax, but these can be quite striking. Okay, so the management, again, proper management includes surveying the patient, making sure, looking at the patient on the whole, and trying not to miss other potentially life-threatening injuries. Of course, you're going to drain the hemothorax, because that's going to be not only diagnostic, but can be therapeutic as well. So you want to look for gross blood, the amount of blood, the blood that comes out over time, whether or not there's a massive air leak, and of course, after you drain the blood, you want to make sure that the space is completely drained. Okay, so this is just one example of a guideline for the need for surgical therapy. It says greater than from 1,000 to 1,500 cc's on initial drainage, and then 300 cc's to 500 for the first hour, or 200, greater than 200 an hour. I mean, there are multiple variations on those recommendations. I tell my residents that if you get a lot of blood out, we're going to the operator. That's my guidance. Okay, if you put in a chest tube and it's all over the floor and all over everybody, and there's 700 or 800 in the canister, you're going to the operator. Okay? So these things, these are not iron cast. Okay, it's all it's based on your diagnostic acumen in terms of when you go to the operating room. Of course, anybody who's unstable goes to the operating room. And then these items below here have to do with persistent or retained hemothorax, which we're going to talk about in a moment. Retained hemothorax can be a problem. Up to about 20% of these patients will have retained blood in the pleural space. And for the most, some of us might say, well, it'll reabsorb. Well, a lot of times it doesn't reabsorb, depending on how much is there. And you can get trapped lung, you can get pneumonia and pyema. Fibrothorax is a kind of a long-term complication of not paying attention to this. But this is a problem, and it's something that can be, for the most part, very easily avoided. So the diagnosis has to do with the amount of fluid present, whether or not it's whether it's heterogeneous or homogeneous.
1 minute.
Okay. So for the most part, what you want to make sure is that you have adequate drainage, and the size and location of your tubes, believe it or not, doesn't really play a role here. There are some people who give antibiotics prior to putting a tube in the trauma slot. I don't know any of you that are. I'm not sure I would even think of it in a patient who has a sizable hemothorax. So, but it's been shown that giving antibiotics and even doing irrigations for patients with small amount of retained hemothorax can prevent that retained hemothorax. So the management for small retained hemothorax, about 25% of the time, if it's less than 300 cc's, you can generally leave those alone. Those will resorb. They won't generally get infected or cause trapping of the lung. A second tube is probably your best bet if you have imaging showing a retained large hemothorax. Putting in a second tube has been shown to be very efficacious in terms of getting rid of that collection. And fibrolytic therapy, a lot of us, I don't know how many of you are out there are using fibrolytic therapy. It generally is, most people are afraid to use it because of the traumatic nature of the injuries to begin with. But it's been shown to be safe and quite efficacious, and you can actually avoid surgery in many of these patients, especially when they have multiple other injuries and they're not really in great shape for having a VATS operation. So don't forget fibrolytic therapy, it does work. And of course, operative intervention is something that I do very early on. Generally, if they call me and we know there's a retained hemothorax, I generally do it within 24 to 48 hours. That's your best bet in getting everything cleaned out and fixing what's going on. So, and I haven't had to do an open drainage for one of these in a long time. So for the most part, you can get away with a single tube, but just remember a second tube is very helpful. Generally, I get IR replacement because then I know exactly where the tube is going. If a patient is a poor surgical candidate, you can use fibrinolytic therapy. Otherwise, I generally take them to the operating room and get it cleaned out. So for the most part, operative intervention for penetrating injuries, not necessary. And for things, for the two injuries we discussed, pneumothorax and hemothorax, for the most part, these can be very easily managed once you have your own protocol based on these studies from the past. And with that, I'll finish. Thank you very much.
Thank you very much for a very elaborate. Because of the time constraint, we have to move to the next speaker. And let me introduce. So we have Peter Myung Ri. He's an American surgeon, medical professor, and a military veteran. During his 24 years in the United States Navy, Dr. Ri has served as a battlefield casualty physician and surgeon in Afghanistan and Iraq. He's a formerly professor of surgery and the chief of trauma, critical care, and burn emergency surgery at the University of Arizona College of Medicine until 2016. He then served as chief of surgery at the Marcus Trauma Center at Grady Memorial Hospital in Atlanta, Georgia. Currently, he's working as the director of the surgical ICU at St. Barnabas Hospital in the Bronx. And he was tenured professor of surgery at the University of Arizona until 2016. Now he's serving as a professor of surgery at the Uniformed Services University of the Health Sciences in Bethesda, Maryland, Morehouse School of Medicine, and is a tenured professor of surgery at the New York Medical College in Valhalla. And he rose to national prominence when he served as an attending surgeon to the U.S. Representative Gabby Gifford of Arizona, as well as other victims following the 2011 Tucson shooting. So, Dr. Ray.
Thank you. I'm going to go as fast as I can, and if I speak too fast, just try to listen slowly. I'm going to give you a little bit of an update. A lot of this is my bias. There'll be some teachings in there, but I'll try to go over the data very quickly. And if you need to get hold of the slides in order to look at the references, we can make that available. So I'll talk a little bit about ED thoracotomy, resuscitated thoracotomy. I was requested to talk about this, and basically I'll try to update you on what I think may or may not be the only relevant change in a long time. Small bore chest tubes, autotransfusion, VATS, chest irrigation, sternal fixation. I won't talk about rear fixation. That'll take too long. All of these can take, obviously, multiple amount of hours to talk about this. But basically, the very quick, simple way to look at chest injury is, whether they're resting, unstable, or stable. But from a teaching purpose, the way I usually talk about this is, are they dead? Are they dying? Or are they okay? The vast majority of people are okay? They're talking to you, they're going to be fine, they might need a tube. But there are a small number of people that are dying, and then we're going to deal with the people who are dead. And this is not so easy. Okay, so the dead people, I don't know how many people here do this on a routine basis, and I'm sure most of us don't, so I'll go over this very quickly. But trying to figure out if a person is dead immediately is not easy to do. So why do we do it? Because we get survivors from these people who are dead, who are physiologically dead. You can't feel a pulse on them, you can't get a rhythm, or sometimes they're flat, right? We can still bring a few back. And I wrote that about 23 years ago, and this held over time. And it was just a meta-analysis of all the publications that were coming out over and over again. But basically, the simple thing to teach in this process is that there's three factors, okay? And this is something that's so easily overlooked by a lot of people. And those factors are, when did you die? If you died yesterday, you're not coming back, right? How you got killed, and then where you're bleeding to death from. If you just answer that question, then you have a much better feeling of when to do this procedure, when not to do it. Obviously, again, in the literature, they talk about it in the ambulance or in the field, but basically, if you just died recently, the better the chances are. And I won't get into the debate of how long ago you died. But stabbing obviously is much harder to kill someone with a knife than it is with a gun. Since gunpowder was invented 500 years ago, it's been revolutionary. And then obviously we figured out how to put gasoline into metal stuff and have cars. So if you get run over by a bus, the chances you're going back are extremely small. And this is important for you to limit your resources, which a lot of places have limitations on. So this is just to say, heart injuries are the most salvageable, and if you die from multiple blood losses, then it's hopeless. So these are just complex slides, but it's only in 2D, it's actually in 3D. So you have to think about these three variables. If you just recently died, or you were alive a few minutes ago from a stab wound to the heart, that's like over a 95% success rate. So in the Eastern guidelines, which just came out not too long ago, same sort of results, same thing, and they debated a little bit about the time. That's basically all I'll tell you about that. Another recent thing done by Joe DeBose says basically the same thing. And then the Western trauma talks a little bit more about when to do blunt penetrating. There are 1 or 2 centers in this country that really promote being aggressive on blunt trauma patients because they have an occasional survivor. So if we can afford that, but it's going to be a lot of cost in order to get that occasional one. But when you do get them back and you get them back early, they'll be neurologically normal the vast majority of the time, over 90%. So the same thing, since this is international, I'll talk about the international literature. Sweden has a little bit better outcome, but they're much more selective on who they do this with, basically. The French basically says it's about the same as all of them. So this is an advice and a point that I'll make for you. That CPR is important, it helps, we know why it helps and so on, I won't get into that detail, but in trauma it doesn't work, Okay, so if you die from exsanguination, pushing on an empty heart doesn't work. So once we realize that, I think we'll go a little faster. So when I worked in Los Angeles, a lot of violence here, we're doing 3 thoracotomies at the same time. Some places never ever do this. Some countries never do these things. So it depends very much on where you work, where you practice. But this has been revolutionary for me. Kenji Inaba, I worked with him for 5 years, good friend of mine. And he basically showed that, you know, if you have a beating heart, you may or may not survive them. But if you have a heart that's not moving, it's worthless. So there is occasional reports that I do here at meetings of someone with no cardiac activity at all. And I've had that as well. You go in, heart's empty and flaccid, you inject it, it does come back. But the long-term results that are infinitesimally small. So this is one of the new decision trees in my algorithm of who I open the chest on or not. We look for the heart activity right away. And that, again, goes to the point that you've got to start and stop CPR. When they're doing CPR, everybody's a little bit places, and you think you have blood going to the brain, you have no blood going to the brain. Okay? So you've got to start stopping CPR. You've got to take the patient over to the bed, and I go exactly backwards of what everybody has been teaching you. I do my primary survey backwards for penetrating injury. I expose them first as a priority, because I have to see the holes. If I don't see the holes, I'm just following algorithms. If they don't have an airway, that's wasting my time, because once somebody starts saying get an airway, I can't see the body. No one will let me turn the body once you start the intubation process until that thing is secure. So I gotta look at them. Disability takes me 3 seconds to do. I look for cardiac activity, I look for circulation, then that's when my decision goes to whether they need to be opened or not. So stop CPR, because you can't roll the patients when they're doing CPR. You can't see what the electrical rhythms are. You can't do a fast an ultrasound with somebody when they're getting their chest pumped on. And if they have no activities, that's DOA. So guy comes in like this, I expose him, I stop. Okay? You're not going to get this person back if he has no signs of life. If he's stabbed, that tells me another thing. Whether they have one gunshot wound, maybe to the ventricle, gunshots are tough to bring back because they're multi-chambered injuries. But if it's on the right side, it tells me something different. If it's in the abdomen, it tells me something different. If they die from exsanguination below the diaphragm, that's tough to get back. If they have a bunch of holes, then I know whether I'm going to try to do a lot of resources. You might open them, might not, but you might not give them blood products. Because once you start that train of giving them blood products, often goes to 20, 50 units right away. So this is a shotgun directly into the chest. I'm not going to open that. That's why it's important to see them. You don't see that if you start with the airway. So I go backwards. I know that's against what everybody says in the whole world, but you heard it here first, so you can start thinking about it on your own. 6 seconds. It takes 6 seconds to take a quick look at the back. No pulses, I'm open. You gotta go fast, and there's a lot of people who don't do this a lot. There's a lot of places that do this very often. And I do say the people who do this very often are more facile with this. The team is used to it, and it becomes routine. If you do it once or twice a year, people are gonna get hurt, including the people with the blades. So, indications that are out there, there's not much change, but the bottom one, ultrasound. No heart activity, that's what makes my decisions. Next part's also going to be extremely controversial. Spent about 10, 15 years working on this process, and that's about pigtails for chest tubes. Chest tubes, they're invasive, traumatic, and painful. Adverse outcomes, you can have them, so on. We just heard a good talk about chest tubes. And the thing is, it's bigger, always better. So, when I was growing up, all the trauma directors told me I never put in anything smaller than a 40. If they made a 50, I'm sure they would use a 50, okay? But 40 was what it is, and if there's blood left in the chest, we're putting in the second one. If I don't see a diaphragm, I'm putting in another one. Now that's what I was taught. If you don't see a diaphragm, you put in another chest tube. So the next slide is rated P, is the video for P for painful. And I'm sure we've all seen this. We never talked about this. But this person, you can't numb up the floor.
They gave him 100,
and that tube goes in, it is painful, and you're bluntly just ripping their whole side, taking a feel. They say there's adhesions. It's very rare to have adhesions. Okay, and then you silence it with level Versed. Versed is very important for chest tubes because you can't take the pain away. Mice can make it so they don't forget. This goes on for 20 more minutes like this, so I'll spare you with this. Okay, size matters. So when we started this, we went gradually from 40 all the way down, and then we categorized it. Kenji and I published this paper. Basically, it says it doesn't matter. Size doesn't matter. Blood comes out of any hole. A good friend of mine, George Velma, taught me this. It says, clot does not come out of any hole. Blood comes out of any hole. You can transfuse through 25 gauge IVs. Lots of stuff comes out through drains, but you can't keep thinking that you're going to get all the clot out with bigger tubes. So these pigtail things, those who have experienced it know the difference. And now that I talked about this, I've been talking about this topic for about 15 years across the country and the world. I know that a lot of hospitals are really adopting this. Anywhere I've gone, it's already been adopted. You can't get residents to just put ripping big tubes into places because they know this works and they know that it's much less painful. So it comes as a kit. It's just like a central line. It's just that easy. All you got to do is get the wire into the space where there's the hematoma or a hemothorax or pneumothorax, and get the wire in, then it's very easy and safe. So I'm going to go through this fast because it's the same sort of stuff. We have about 7 publications on the same topic over and over again. There's complications from this, just like there are from anything that we do, and anything that a resident can get a hold of, they will stick it into whatever places that we can, including attendings. This one's in the vena cava, but there's also chest tubes in the liver. We've all seen chest tubes in the spleen, the stomach, and that's anywhere. So, but the complication rate and the blood rate is actually all the same. So can it take out the blood? I think there's no question that it does really well for pneumothorax. And this is a clot, and you do a thoracotomy. That clot does not come out of any side. The chest clots like crazy. It's got tons and tons of tissue factor in there. It does that. Lots of studies talking about how well things come out of the drains. It does make a little bit of a difference in the rate, but in 10 minutes, it's no big difference at all. So, small catheter tubes, stable patients. First came out in pediatric patients, but we were doing this as IR guided, but we started doing this on trauma patients, doing it backwards, forwards, retrospectively, cohort studies, and so on. And this is the part that we started looking at this trend. We kept finding out the smaller tubes is equal, if not more, which tells you the fact that blood comes out of any size hole. Failure rate, complication rates, all this, I won't go into too much detail. Less pain, prospective randomized studies done on this, yada, yada, yada. It's all about the same. We all know that it works. Last thought again, unclotted blood will not come out of any hole, and blood will come out of any hole. So, indications for thoracotomy, we know what it is, won't go into it in detail. I like to see how much it's bled. The second important thing is, are they bleeding? If you are still bleeding, I don't care how much you got out and you're unstable, we need to think about surgery sooner. But there's a lot of patients who've have a lot of blood out that is no longer bleeding, and taking them to the OR just to open them up doesn't do much. So keep that in mind, but whether you're doing this or not, it depends also on the color of the blood. If it's black blood coming out, you could need nothing, but if it's bright red stuff coming out, pay attention to it. So auto transfusion of this is what I'm talking about, basically. So what do we do with the blood that we take out of it? We throw it away. But there's ways to put this back into the chest, and this was debated and controversial for a long period of time. So we studied it and published it, and basically says you can take the blood and give it back any way you want. We used to do this on Iraq. Lots of countries do all sorts of things to take out the blood, filter in all sorts of different ways, squeeze out wrap sponges and so on. We know giving the patient blood back is okay, safe, and easy to do. This is a video of a nurse who just cracks it open. There's many kits on how to do this, many manufacturers working on a newer, better way. But the one thing is the Pluravac system is the most archaic, old-fashioned thing you could ever come across. And if you want to make a lot of money, we can talk about a better, easier device. So when we did this, we did a human study on it, basically proved them that you can give their own blood back, it's safe, there's no complications, and it reduces money, and you don't have to give strangers blood. So here's a case that I am embarrassed to talk about because I know that if the American Board of Surgery found out of it, they would take my boards away. The guy gets shot in the back. comes out under the clavicle. For a trauma surgeon, that smells like subclavian stuff. That's actually a fun case to do. I don't want to say that too much. But I was actually operating on another patient after we put a pigtail in this patient. The CT scan shows the subclavian artery is okay. Okay, most of the bleeding usually comes from either the surrounding vessels like the subclavian stuff or the intercostals. But rarely did this tract also did not go into the hilum, so we need this. I was operating on another patient, and they come in and tell me that this patient who got drained with a pigtail has got 1.5 liters out of the chest tube. First of all, through the pigtail, okay? So my first question is, okay, book them for the room, bring the patient to the operating room, and how's the patient doing? The resident says, I'll be back. So he comes back about 10 minutes later, and I go, how's the patient doing? He's perfectly fine, tells me perfectly normal vital signs, how much is coming out of the tube? He says, it's still coming out of the tube. Well, all right, hurry, bring him back to the operating room. This was about 5 or 6 in the morning. And then as we're getting going, I can't find the patient. Where's the patient? He's in the ICU with a little pigtail in place. Obviously, he's sleeping well. It's about 2 hours, 3 hours from the injury. Now, I would not recommend this, but I'm going to show you his vitals, which are completely normal. He bled 3 liters out of the chest. And why did he not have a surgery? Because at that time, he was no longer bleeding. Chest X-ray looked fine. The tube was no longer bleeding. But the reason why he looked so good was because the nurses automatically was giving back all his blood. All of it was his own blood. VATS I won't talk about, but I do agree if you don't do, unless you do VATS for a small amount of blood, I usually put my limitation at 300 cc's as well. If I put in a tube, big tube, little tube, small tube, whatever you put in a day, if I don't see a good diaphragm, I scan him. If it looks like it's got a retained pneumothorax, I schedule him for a VATS because you just take him to the OR, suck it out. Very easy thing for the patients to do. I don't do fibrolytics anymore because I did that study with Brian Kimbrough. It's a total painful procedure for both the residents and yourself and the patients as well. But there's another one that's coming out, and that's about this new irrigator. This is becoming very trendy. They're selling this product at all the trauma meetings. All I can tell you for that is that is not that great. So we'll have to see how it goes. And then the final thing I'll talk about is thoracic fractures. That one didn't show all the way, but I don't care about the displacement of the thoracic of the sternum. So this is the one area that I actually do a lot of surgery for if it comes around. Now, why do you fix their sternum? But we've gone for many, many years without fixing the sternum. And you don't have to fix anything. There's lots of ways to do it. You can tie a stick to your femur fracture. But when's the last time any one of us have seen a femur fracture not be fixed? Okay, in Mexico I've been to one where they don't have the rods, so by the time they get it in 6 weeks, the bone's already healed. But we fix just about everything nowadays, including the clavicle and the humerus. So what's the advantage? You get mobilized and it's pain-free and the patient doesn't suffer for a month. So that's the main reason why I do the sternal fixation. I don't do rib fixations for pain. It's too complicated. I don't know the indications for rib fixations. And although there are some algorithms out there, I don't necessarily agree with them all. But this sternal fixation stuff is very easy. I just basically say, if he can't get out of bed, I'll offer them the surgery. Okay, this guy, perfectly fine, but he's not moving around, but he can't get out of bed. And it hurts right where you're pushing on it, right there. Okay, and especially old ladies. Okay, the ones that can't, their eyebrows are stuck to the top of the head because of their pain, can't get out of bed. You fix them. It's a 20-minute procedure, and the next day they just get right up.
Let me get where's your
It hurts a
pain?
lot. Wherever they point to, that's what I fix. Lidocaine patches don't work. I'll talk to you about that another time. You often buy me a beer.
This is okay up here?
But it's just pinpoint, pain. That's where the fracture is.
And this is okay down here, right?
You put in whatever kind of stuff that you want, but nowadays the kits all come in different sizes and shapes, and they come up with these little small plates, so the surgeries become smaller and smaller, and it's a great way to alleviate their pain. So I do it for pain, for stabilizations, also non-union. Some people, they've been hurting for about a year. They can't golf and things like that, so that's when I'll also do it. So that's it, and I'll end here.
We have a short time for Quick questions, please. Yes.
Good morning. I'm Lorenzo from Dallas. Great lectures on this. My question is quick. The sternal fractures, do you have any complications? Also,
I did have one. I've had one. I've been doing this for about 15 years as well. And this is still, I'm still playing with this and trying to get more idea what to do. And this guy was fixing, he was on the riding lawnmower that you stand up, but it toppled over and broke his sternum. And he was just in excruciating pain. But his fracture was at the manubrium joint. So that joint still has a little bit of mobility. And if you fix that, you know, it can decrease a little bit of his chest mobility. So I went ahead and planted that. And he was so happy with that, he went right back to working, and the two top screws fell out, so I took it back and put it in another one. But I've never so far have had an infection or any other complications with that. Never had it where it went into the heart or anything like that either. So I usually go a little longer than they recommend. I like the tip to go right past the lower table, and it seems to be very firm.
Dr. Santana from Weill, Texas. Excellent presentation. You mentioned that you don't typically break ribs, but then there's growing literature that it works for pain control, and that in turn helps with earlier extubation, less incidence of post-traumatic pneumonia. It seems that overall the patient may have a faster recovery. Perhaps the elderly population might be the one that benefits the most. So can you elaborate your thoughts on perhaps why you don't do that?
Briefly, we just did one the other week, and he ended up in the unit for 2 weeks with all sorts of complications, including bleeding into his lungs and so on. So that guy, he had 9 fractures. Okay, he had a whole bunch of other injuries as well, including lung contusions, and they took the opportunity to go in there and they fixed 3 of the 9. So I have a little bit of a problem doing just the most convenient ribs, and that's some of the reasons why. Sometimes they'll get assaulted, they'll crack a rib, it hurts, but they seem to be doing pretty good, so go in there and put in a metal plate on that one particular rib. Do they get that much of a relief? I think if they couldn't get out of bed, I'd offer it to them. Okay, if they couldn't get out of bed, I think that's all right. But usually these people have, they have spine fractures, they have acetabular fractures, they have all sorts of reasons why they don't get mobilized. And I do think that the time and the place to do some of these things, the greatest way is if they have about 2 or 3 isolated rib fractures, and they got a retained hemothorax, and you're going to go in there for a VATS. When you do that, you can put in an internal system, and then you can also freeze the nerves to get a lot of the pain relief out of that. And that lasts for about 6 weeks. But to go in there, open up the skin, take these crunchy ribs, all of them, put in huge long ones, 4, 5, 6 of them, 6 out of 9, 6 out of 10. If you did 3 out of 3, that would make some sense. Sometimes you go onto the scapula. I think when you dissect into the scapula, you put the stuff in there, they have long-term chronic pain problems and issues. A lot of times you fix the convenient ones, which are anterior, but you don't fix the posterior portion of it. So I'm not so sure we're doing a great complete job. So I've gone through full cycle where I was very aggressive with the fixations, and then backed off on it, and I'm always looking for the ideal candidate. I'm not completely against it. It's just that I don't offer it to everybody because I don't think I understand the indications yet. And the guy who started the whole process, the one thing he made me swear to never do is operate for pain. Because he says when you operate for pain, you're going to get more pain, and he does more of these rib fixations, John Mayberry, than anybody else that I know. He also does a lot of chronic pain patients as well. Chronic pain ones, when you go in, cut a piece of rib and so on, that's a different topic as well. But in the acute phase, I don't know the indications that well. That's the reason why I don't promote it.
Okay, thank you very much. Thank you.
Dr. Tony Kapatsis, he is the Director of Surgical Trauma ICU at Elmhurst Hospital, Queens Hospital, and also Fellowship Director at the Mount Sinai School of Medicine in New York City.
think Sharique do this to me every year. I have to follow some great presentation with videos and pictures, and I'm going to slow this down to a complete stop with some original research. I want to thank the International College of Surgeons for allowing me to come back here. This is my 4th time, and I appreciate it. It's an honor and a privilege. I'm going to discuss something not as sexy as the previous presentation, but I think it goes hand in hand with what Dr. Reed was talking about. This is one of our original projects. We have a fellowship, and we do a bunch of projects. We present this at SAGES. It's massive transfusion trauma does payer status as a proxy to healthcare disparities, decreased fetal transfusions. I have no disclosures. Just a little quick background. I know we're short on time, so I'll move quickly. Elmhurst Hospital is one of 11 public 11 hospitals in the H&H system. It's the largest system in America. It composes of 6 trauma centers. My hospital is 545 beds, and it's part of the teaching hospital affiliate with Mount Sinai. If you guys don't know what New York's all about, New York State's about 24 million people. New York City itself, composed of 5 boroughs, has about 8 to 10 million people. 3 million is in Brooklyn, and about 2.2 to 2.5 million is in Queens alone. We control the western portion of Queens. Elmhurst Hospital received its notoriety from the COVID pandemic. We have almost 100 different languages, 500 different dialects. We're right on the poverty level, sort of impoverished in that region itself. Everybody's basically on top of each other. That's why it was ground zero during the COVID pandemic at that time. So a little bit of background of what I'm going to talk about. Blood shortages are a national crisis, creating dangerous scenarios for patients requiring MTPs in the trauma setting. You know, HLS has taught us that we went from fluids always right down to blood, and now everybody's an MTP. So we have to be pretty smart about, you know, we have to start thinking about judicious blood product for patients and refrain from giving unnecessary MTPs. I mean, every app site, CSAP, and every board question, and a trauma patient comes in, immediately you go get blood. I mean, and without even thinking, everybody's transfused because everybody's excited, there's a penetrating injury, et cetera, et cetera. So what is our aim? Trying to show a relationship between the futility, between ER deaths and patients receiving MTP. Then we took some futility markers in correlation to transfusions, MTPs itself, and can we predict ER deaths from an MTP transfusion? So it all sounds like stuff that we've done before, but we found something that we think is interesting. So what were our methods? We did a retrospective review during only 5 years. We're going to go back 5 more years before that. This is kind of a strange time. People in New York during the pandemic, we didn't have as many trauma patients, more of the COVID patients, especially in my institution. Then we had a big rush of trauma patients because of social disturbances and what have you, and sort of even things out. We took MTP during initial resuscitation, as well as baseline patient trauma event characteristics and payer status, again, as a proxy of healthcare disparities. We took patients who had activated and not activated MTP. We did a multivariate analysis that assessed the relation between MTP transfusions, activation AD, the demographic characteristics, as well as what we call futility markers. And what is our patient characteristics? About 11,000 patients with a mortality rate about 1.2%. We found out the median age of patients receiving MTP was younger. Our population was a bit younger. Penetrating trauma, nothing unusual, received the most MTP. And then patients who had blunt force trauma were less likely to receive MTP with such trauma itself. And finally, the statistical significance of MTP activation status was based on gender, with more men than women receiving MTP. Nothing unusual because a lot of men have trauma. We discussed about age, our younger age group, male being more predominant. You know, race is interesting in the area of Elmhurst. We have a very strong Asian population. It doesn't manifest in here. I imagine it's in the other category. Ethnicity, again, we have about 1/3 amount of Hispanic and non-Hispanic, and it's probably mostly like our Asian community. And payer status is Medicaid, which is a safety net hospital, urban setting. But if you throw in, I guess, no charge, other, self and unknown, you're probably get close to more than 50%. And that's not unusual for a safety net hospital. So our markers of futility in MTP transfusion status is the ISS and probability of survival. Reported in the data was significantly negatively correlated. That makes sense too, with the Kendall coefficient, the sicker you are, higher chance of mortality. ISS was higher in patients receiving MTP than in those who did not, reaffirming and confirming stuff that we already know. And median PS was lower in MTP and transfusion. Yes, okay. So we get a little nerdy with some statistics. It's not my area of expertise. Thank goodness I have fellows. The RSC curve, packed red blood cells, which is MTP, versus whether or not patient died. And you can see from under the area curve that there is a correlation with death and MTP. Getting to the markers of futility, we found statistically significant in age that patients who were younger received MTP. Thank goodness, race or ethnicity have nothing to play in this, but we're going to continue with our project. Payer source, Medicaid and Medicare may be some sort of trend there. Penetrating trauma is statistically significant, not ISS, but PSS along with ISS together create a statistically significant MTP transfusion. So what was our conclusions? That patients with penetrating trauma are more likely to receive MTP, but regardless of their probability of survival. So what Dr. Reed said, you flip the patient around, you see multiple gunshot wounds, what's the chance of survivability? If you're in an institution that's a level 2, maybe not a level 2, I'm sorry, there's some level 2 programs that are much busier than level 1 programs that are not used to penetrating trauma. They may say, let's shove all this blood, and we have the ER staff, we have ER residency, they're all excited, and without even thinking, we're giving it already. Patients over the age of 15 years and patients with blood trauma are less likely to receive MTP, and we'll discuss that in a second. And MTP transfusion associated with ED deaths, confirming that. Assessing futility of MTP should be equitable, and future transfusion guidelines should consider salvageability in cases with low probability of survival despite age and mechanism, and that is their bias in the Bay. So clear understanding of the mechanism of extensive injury, just like what Dr. Reed said, you know, blunt versus penetrating. We may have a elderly patient that's very healthy in their 70s compared to maybe a young patient that is not as healthy with clear survivability of the injury itself. So that has to be thought of. Next, which is the age, which I've just described. Difference between age and elderly, and sometimes we have to rethink those things. Blood product shortages, very, very important. Everybody's constantly giving blood. I mean, I give blood every 90 days, and when my residents give too much blood, I ask them to come with me and give blood with me. Platelets are much difficult, and I needed more, so I try to make them give platelets. So we have to have in the back of our mind, we can't keep just constantly opening up the MTP for everybody. And finally, surgeons experience awareness. I find this now being more of the elderly veteran type of situation. I have some young guns and young attendees, and they're also so very excited taking everybody to the operating room because it's a lot of stuff we do is conservatively. And they're just pouring blood. And I think along with the ER staff, we're doing the same thing. And that's taken away from the trauma surgeons also. So what's our implication of change? Self-awareness and personal bias, which are these keywords now these days on everything, is a consideration for MTP versus salvage of blood products. Call for a multi-central trial. Well, I have 10 other hospitals I can work with. If I can convince anybody out there, that would be great also. And creation of equitable MTP guidelines or precision distribution of blood products. That's all we need is another guideline on the policy, but I think it's important here, especially when we have national shortages. Thank you.
Thank you very much. We have time for a couple of questions. Yes, please.
So
so I'm far from being a trauma surgeon, so sorry, it's not even a question. But you had mentioned self-awareness. Do your surgeons get feedback on how often they use MTP and how much blood they use? Is there kind of feedback loop?
Oh yeah, I mean, we have a trauma PI every month, like every good level 1 trauma center does, and aware of how much is being given. I mean, it's a constant fight between ER and trauma surgeons. You know, we try to play nice in the sandbox, which can be hard at times, and all work together and pointing fingers, but we do and do the best we can. And maybe this will give us more incentive to sort of work on that, our PIs. Thank you.
I have a question.
Yes.
So the question of survivability, and sitting in trauma peer reviews, you hear, this injury in retrospect was non-survivable.
Yes.
So is MTP a sort of a bridge to decision, saying, okay, let's give MTP and see at some point whether this is survivable or not?
Yes, I agree, and I think that comes in with surgical experience, like Dr. Reed. I do appreciate, I know I mentioned your name multiple times, in exposing the patient to see what the injury is. But a lot of times we have our colleagues already trying to intubate, which is a very dangerous thing to do with penetrating trauma on the border of crashing. And if we do have that time and there is some cardiac activity, we go ahead, again, trying to play nice in the sandbox. But where is that line where eventually say, hey, we have to stop? And I've had trauma surgeons stop the ER attending, and we don't want to embarrass anybody in front of residents, stuff like that, but eventually, you whisper in their ear. But you're right, there's a fine line, there's a gray line there.
Thank you very much.
Thank you.
Thank you for sharing your research at our college meeting here. And we would like to welcome from Czechoslovakia one of the great surgeons from there, Dr. Peter Nazir, who is a trauma surgeon at the University Hospital, Brno, Czechoslovakia Republic. Who's going to talk about the blunt chest trauma, past and present.
Mr. Chairman, ladies and gentlemen, thank you very much for the invitation in Texas and San Antonio from Czech Republic. And I can present our experiences with the blunt chest injuries in Czech Republic and in our trauma center. Our trauma center is in University Hospital in Brno. Our hospital is the second biggest hospital in Czech Republic. We have 950 beds, 78 departments, 40 operating theaters, complement and 2 reports for heavy traumas and polytraumas. Our region is 24 hours service for heavy traumas and polytrauma patients. There are 2 regions, South Moravia and Vysočina land. They are here. And we have about 1.7 million residents. It's the biggest trauma center in Czech Republic. So in our country, there is motorization, highways, industry, tourism, biking, and other sport activities. So we have many patients from these potentially donors. Our key departments have together 115 beds. There are only for heavy patients and heavy trauma and polytraumas. There are emergency and restoration, intensive care, trauma surgery and surgery department, neurology, neurosurgery, radiology, and the other is complement to our complex health treatment of the health patients. Our emergency have 8 beds. There are complex equipment for resuscitation. We have good condition for diagnosis, CT, ultrasonography, X-ray, X-ray basic laboratory, ROTEM, and we have there the emergency operating room for the heavy patients with our in a life disaster. So this is our emergency, and you can see our patients in emergency in 11 years. It is about 40–50% of trauma patients in our emergency. The injury of chest incidents It is blunt injuries. There are about 13% of all traumas. And chest trauma and polytrauma is presented in 75%, and blunt injuries in 98%, and cause of death is 25% from these patients. Great mortality is in door fractures. There are about 40%, not on emergency, but in the treatment of the heavy trauma and polytrauma. We have simple fractures in 57%, bilateral fractures about 20%, serial fractures 36%, and bilateral fractures is very difficult for the patient in 29%, and door fractures in about 7% in our patients. Chest wall injury, it is the pain, ventilation disorders, but we have the complications with lung injury, contusions, laceration, was said before me, and complications, bronchopneumonia, pulmonary atherosclerosis, hemothorax, and pneumothorax. So we must make some diagnosis and some complete treatment. In the history of the chest drainage, it started in 18th century, but the surgeons must make the suction through the mouth of a surgeon. Then it was their RSP syringe, improving puncture hygiene, and in England the doctors make the underwater aspiration systems, and the great experiences were in American Civil War. It was the threatening Wales in 1964, and in this time it is the Heimlich valve which is used in the patient by the transport to the trauma center. And dominant now is the underwater drainage. The treatment of the blunt chest injury is a helix. Once more conservative, also operating, and it goes through the centuries in the treatment. In the history, the conservative treatment previously most injuries, but now less courageous, less qualified, and less experienced surgeons. And operative, there are the new surgeons. In 19th century, Repeater and Kapstein, and that treatment, laceration and damage of the lungs. The great experiences were in the First World War. It is the majority of injuries were treated conservatively, but it was excessive mortality there. But the surgeons, Shabsigh, Weill, make surgical solutions. They have better results. Early thoracotomy, treatment of lung injury, and their mortality is under 20%. So it was very good for the patient and for the soldiers in this First World War. The start of the treatment of blunt injuries, it started with some immobilization and external fixation of the chest wall. It was compressed adhesive tapes, the wrinkle respirator is here, and a Cape Town iron pad. So there were methods in the start of the treatment of the blunt trauma. After them were reposition solutions. There were forceps, soundringer here, screws, wire loops, and corkscrew as the external traction of the thoracic wall to the reposition and primary stabilization of the chest wall. In 1951, they started with tracheostomy and intermittent ventilation. So 1955, it was artificial lung ventilation. It says an internal pneumatic splint of the thoracic wall. And in the last century, in 70s and 80s years, it was external compression. It was cingulum, analgetics, and there were complications, bronchopneumonia, and it was very bad for the patient with immobilized chest wall. Operative treatment started with fixation with key wires, external sprints, some operators, external fixator, and inner sprint, you can see here in the pictures, but it was not very good for the patients. And we started with osteosynthesis. There were some methods for osteosynthesis, wire loops and stitches, splint, intramedullary splints, and pins and bone pins. You can see this implant here. And after them, the treatment in 80s and 90s of the surgery, simple and sterile fractures without deformity and without fire breathing mechanics. It was analgesics, breathing exercises, and patient mobilization. It was without fixation of the chest wall. It was better for the patients as a prevent of the complications. By the multiple fractures with deformity of chest and chest wall and impaired breathing mechanism, it was in the start the internal pneumatic splint, long-term artificial ventilation with positive and PEEP. And after them, we started with stabilization of the chest wall, osteosynthesis of rib fractures. It was a Ledicke splint, and in Czech Republic, modification from firma Beznovská. It was the company who made the traumatological implants. Disadvantage of these splints was selective intubation, PEEP, tracheostomy, and aggressive bronchial tree Tourette's, infection complications, limits of physiotherapy. Patients can make some movements, and cost of hospitalization time. And after the consequences was chest deformity and lung volume reduction. It was bad for the patient. And the review of the osteosynthesis of rib fractures in Czech Republic started Professor Mikek in 1989. It was rib splint from firma Medin. It was the second factory in Czech Republic with traumatological implants. There was the complete instrumentarium in the place with here compressed stitches that surround the ribs. And it was advantage stabilization of the chest wall, improvement of breathing mechanics, but against the surgical wound that we used as an approach, a vertical approach, and we stabilized many ribs fractures. And the risk it was of the failure of osteosynthesis and complication of the wound. So it was very bad for our intensive care doctors. And now, in present, there are single and multiple fractures without deformity of chest wall, without breathing impaired. So it is analgesis, breathing exercises, mobilizing the patient, and we make regular checks, X-ray controls every two weeks about the pneumothorax or pneumothorax. New operation methods started in 2015. This is Professor Vinanek in Prague. It was new implants with screws. Advantage it was better stability and looping screws. They were locked here in the plate, and this was great stability. But the disadvantage was the chest wall disruption with the forceps of the plate surrounding the rib, soft tissue damages, and the complications of the wound healing. In this time, we use a matrix rib fixation system from Depew Synthes. They are placed, preform placed, and stride placed, intramedullary splints, and the looping screws. That is very good for the stability of the osteosynthesis. There are no many complications as in the before instruments. So treatment strategy. In emergency, void trauma protocol. The patient accept the examination in helical CTs, and we make 3D reconstruction. It is very necessary for the surgeons to study the localization and the type of the fractures and dislocations of the rib fractures. And the indications for the chest wall stabilization, there are surgical and anesthesiological of intensive care doctors. Timing of surgery. In the first, there is life-saving surgery. This is the early total care, and after that, the damage control surgery. And in our experience, the primary chest wall stabilization within 48 and 72 hours or 2 or 3 days after heavy trauma. Secondary indications, there are intrathoracic complications, tracheostomy, and continued instability of the chest deformities in ancestral weaning. So the indications after the 3D reconstructions, dislocation of the ribs and locality of the fractures, and the lung injury, there are surgical indications with the severity of the chest wall injury, bare chest, and deformity of the chest wall, and the volume reduction of the chest cavity more than 30%, and with them lung injury or perforation or permanent bleeding, and it was said before me. The anesthesiological indications, there are the mechanical ventilation disorders, blood gases, POC, and PCO2, decrease in ventilation parameters, ineffective artificial ventilation, pulmonary confusion, disconnection from the ventilator, chronic lung disease, and nursing care, especially in polytrauma patients. So we must take some conclusion, trauma surgeon and intensive care doctors, and we indicate chest wall stabilization, and for optimization of the ventilation parameters, ventilation strategy, disconnection from the ventilator, pain control, respiratory hygiene. The timing of the surgery is from the 48 to 72 hours after injury, but it is after the overall condition of the patient. It is the big factor which is involving the stabilization of the chest wall. So contraindications and conditions for chest wall stabilization: age more than 45 years. Polytrauma, it is for discussion. It is after the stability of the patients. Severe craniocerebral injury, hemodynamic instability, and unstable fractures of the spine and pelvis with spinal cord injuries. Our results in 10 years.
2 minutes. 2 minutes.
Bronx chest
2 minutes.
injuries, hospitalized 924 patients, in polytrauma 148 patients, surgical solutions in 105 patients. Our co-traumas in the patients, there are many co-traumas in the patients. So in our surgery solutions, 905 patients, unilateral fractures 71, lateral fractures 34 patients, and we stabilized from 2 to 4 and more ribs on one side or on both sides of the thorax. Our complications was osteotomy failure, it was LCP phase, no complications, malposition of the spring, second loop, pneumonia, screw dislocation, and valve infection in one patient after 2 years. Mortality 0, morbidity tabula 1. So our benefits: shortening of the length of ventilation to stay on intensive care unit, small percentage of indications for tracheostomy, ear immobilizations, reduction of the pneumonia mortality, use of analgesics, and consequences. Surgery versus conservative, they are 34 to 60% of the patients. So now I can, in the end, show our patients in our mission in Nepal in 2015 after the earthquake. We were there as advanced medical post, chest emergency rescue team. We have 2 patients there. One patient about 80 years. The oxygen 56%, with oxygen 78%. And both thorax drainage, and the women about 45 years, both fractures of the both chest, without oxygen 40%, with oxygen 62%. Both patients were transported by helicopter to the field hospital, to Kathmandu of Indian field hospital. So it was our experiences with chest trauma. Thank you very much for your attention.
Thank you very much, very good presentation in elaborate discussion about the management of the rib fractures. So because of time constraint, we're going to move to the last but not the least. And he's one of the regent member also from North Carolina, Dr. Biswas, Associate Program Director, Neurosurgery Residency Program, and Director of the Surgical Research and Simulation Grant Strand Medical Center, who's going to talk about the intercostal nerve cryo ablation provides effective analgesia when used as an adjunct to rib fracture stabilization. Recent evidences.
Thank you, everybody. Is it still good afternoon or good morning? Good morning, everybody, and thanks for the opportunity. It's a very difficult task to follow such luminaries. I have one disclosure, like I'm an Indian, and after 20 years in America, I've not been able to change my accent. So please bear with me and stop me if I'm if you're not able to understand, I'll repeat again. So I'm going to talk about intercostal nerve blocks with those cryo. It's a new technique that we are using. It's been used in thoracic surgery before, and most of the literature is based on thoracic surgery and NAS procedures. But more commonly, we're using more and more in rib fractures. As on previous speaker mentioned, like they have been doing a lot of rib fractures. I personally have been doing a lot of rib fractures, and I'm a bit of a proponent as far as rib fractures are concerned. So with due respect to Dr. Ree, like I do believe that you do not have to basically do all the ribs. Yeah, you can probably do 3 to 7, which is probably the one which form the structural basis of it. And then after that, if it's significantly displaced, there is a thoracic society, chest wall society, which has annual meetings every year, and that has like membership from trauma surgeons to thoracic surgeons to orthopedic surgeons, and they come up with new guidelines every year. It keeps on changing. So I personally believe in the lung volume of like 30, as you mentioned, significant thoracic trauma with more than 50% displacement of the ribs in more than 3 ribs, or pain out of proportions. Those are my criteria for doing rib fractures. So I do not have any financial disclosures. Like this is the talk about cryo ablation. So there will be slides from Adicure, which is the company which makes this cryo, and then some of the slides are provided by them, but I have nothing to disclose. So as regards pain is concerned, in trauma we can think about global methods and we can think about local methods. The global methods are the ones we normally use, like epidural analgesia, spinal analgesia, and intravenous pain medications and oral pain medications, as you will know. And local methods are the paravertebral blocks and interspinal blocks, and now we've added this cryo neuro block. So pain types broadly can be classified into neuropathic pain, inflammatory pain, and biopsychological pain, and nociceptive pain can again be divided into visceral and somatic. And this cryo neuro blocks are the ones which normally targets those somatic ones. So we found out that intercostal nerve blocks, cryoablations, although it's somewhat new as far as applications in rib stabilization is concerned, is so far has been proved to be safe, although like a lot to be desired as far as long-term outcomes and stuff, because we're still in infancy, probably more than like 4 or 5 years now. It does provide targeted analgesia for rib fractures, There have been other avenues like regional and neuroaxial nerve blocks which provide targeted analgesia, but they are typically short-lived, and the surgeons must rely on their anesthesia colleagues, which can sometimes be difficult at times. Reported complications in contemporary literature includes chest wall paresthesia and spontaneously dissolving hematoma. There have been reports of neuralgia and neuroma formations, but of late the incidence has been significantly low. So the Intercostal cryo was first started for post-thoracotomy pain way back in 1974 by Nelson et al., and this was in regards to thoracic trauma. Direct application of the cryoprobe to a peripheral nerve results in a Sunderland stage 2 nerve injury. We call it axontomesis. So going back to physiology, we have like nerve injury can be classified into Seddon's classification and Sutherland's classification. And I have a couple of slides later on coming up. I can be able to explain better. So in this type, what we normally do is that we deliberately target the nerve axon and the myelin sheath, and they are destroyed. But the endoneural, the perineural, and the epinural remains intact. And from those structures, they grow back, the nerves grow back at the rate of like 1 to 2 millimeter per day, and it usually takes like 2 to 3 months for the grow back to happen. And this is followed by Wallerian degeneration of the distal nerve from the point of affection of this cryo, and resulting in numbness distal to the nerve lesion. As I said, like 1 to 3 millimeter per day is the growth. So this is the dermatome. This is important from the point of view that when I'm doing a cryo for my post rib stabilization, I usually go from 3 to 9. Below 9, they can have like side effect of pseudodiastasis. They can be having abnormal distension of the abdomen, and then above 3, you can have ptosis. I never had a complication like this, but I did have like one patient with abdominal distension, significant distension, so much so that we were concerned that we were missing a large wall obstruction or something. But it is self-reducing, and it reduces within like 6 to 8 weeks. Here's another anatomical picture of the nerve distribution. So this is how I don't have a video, but this is one of the techniques you do, like you can do it with VATS. In fact, most of the studies that they recommend are using VATS. I use VATS selectively. In some patients who are not able to tolerate double lumen, I normally use a normal open thoracic technique. And as far as I'm concerned, use a technique like this where you pick up the ribs and you target it from 3 to 9, and you go from 3 to 9 in the intercostal space, so in the inferior portion of the intercostal space, and target the groove. And then you hold it for 2 minutes. This is the better view, but then this is the VATS view. And in the VATS, what you do is like you normally go in, your landmarks are 2 centimeters from the ganglion and 4 centimeters from the spine. You don't want to go in there nearby. You can have a chance of having adverse injuries from that. But the green area is the one where you are able to target. And that is the area which we normally do. And irrespective of the number of rib fractures, we normally do 4 to 9, and that has shown to have significant results, better results as far as pain control is concerned. And talking about the method, what we normally do is like, so as I said, like in selected cases, I do the VATS, and this is the procedure you do. You select from 4 to 9, and you basically go in every intercostal space and do it for 2 minutes. And I do it extrathoracically for most of my cases, except the patients where I'm doing VATS. So those patients, again, like the incision already has been made, and I choose the ribs, and I go there and put in a spear, like so it's shaped like a long handle with a spear. And so you put in the spear in this intercostal groove, and then you keep it there for like 2 minutes. and the temperature normally is regulated. It's like minus 60 to minus 90. I normally set it to like around about like minus 64 to minus 67. And after a few minutes, like after 2 minutes, when it's near about 2 minutes, it automatically cools down. It warms up, in fact, and then you are able to take it back. And during this time, you need to hold still. You don't have to move your probe, and it shows good results. The importance is the minus 50 to minus 70, because if you go above that, above 100, then there is a significant chance of having damage to the other structures, like the endo-peri-neural structures, and that can cause significant long-term damage. And then the chances of regeneration significantly decreases. This is again like a bigger view of that green zone where you're going to target. This is again the same thing, which says that like it doesn't depend on the length of the nerve that you're putting in the cryo in, but it targets the position of that nerve that you're targeting it. And it grows back towards your sternum. So that's the way it normally happens. Postoperatively, the regeneration of the axons occurs from the cryo ablation site to the end organs, which is towards the sternum. The axons within the intercostal nerve that sends pain signals are destroyed distal to the cryo ablation site. And then this epineurium, the perineurium, and the endoneurium of the nerve remains intact, and from where the nerve grows back. So this is like, as I mentioned at the beginning of my talk, that most of this is a new technique, so most of the literature is from isolated case reports and small case series. There are only probably like 3 or 4 literature which involves like multiple patients. I'm going to talk about them in a few minutes. This is again showing multiple rib fractures, and this is a view with the VATS showing the places which are getting cryo ablations. Again, this is the classification I was talking about. So you have neuropraxia, and which is like a grade 1, where it involves only the axon, only the myelin sheath. And so then you have like axonomasis. This is the one we are talking about, which is a Sutherland grade 2, where you have the myelin and the axon, which are targeted. And so you have the endoneurium and the perineurium and the epineurium, which are intact. And from those, the new structures grow back in 2 or 3 months' time. And obviously there are like 3, 4, 5, which are severe injuries where the chances of coming back are significantly low. This is the structure I was talking about. You can see here the axon and the myelin sheath on top of that, along with the endoneurium, the perineurium, and the epineurium. These are the structure which are involved in the regeneration of the nerves later on. So these are like some of the studies. This is like way back in, not way back, 2019. So it's a multi-institutional study by Zhao et al. And, but it only involved like 13 patients. And they talked about pre and post-operative pain scores, completeness of nerve function return, and diastasis experiencing during the healing process. And their median age was 58. The median number of fractures was 7. Important thing, as one of my previous speakers have mentioned, the mean time to operation was 2.1 plus minus 1.2. That is important because you target to complete your rib stabilization within 2 to 3 days, if it's possible. But as Dr. Ray specifically mentioned, that you do have like other comorbidities, mostly fractures like acetabular fractures, unstable spinal fractures, pelvic fractures, and that needs to be fixed first because depending on the position of the ribs, we normally position the patient. We need to break the table of the OR table, and that basically is not possible unless they are fixed first. So that usually delays. Sometimes they're delayed so much because orthopedics is busy, everybody's busy. So that pushes them back so much that callus formation is always beginning to happen. In that case, we have to re-break the ribs and stabilize it. So there's another study, which is probably one of the most well-known studies by Bowman et al. And they looked at multiple features where they, significant here is the number of days, the total hospital length of stay. And here, like patients who had only rib stabilization done was 10. And it was not significantly different from the one with cryo ablation, but it was definitely smaller. It's like 9. But post-operative hospital length of stay also was somewhat smaller, 4 compared to 6. They also considered about the cost involved and also about the narcotics involvement in this patient. So here I've broken down. This was a multi-institutional retrospective study over an 8-year-old period. 92 involved rib stabilization, 44 underwent rib stabilization with cryo ablation. And in this cryo ablation group, there was, like as I mentioned, 9 out of versus 10, and in length of stay versus 4 out of 6 in the post-operative period. So they have also mentioned about the cost. The cost was also significant as far as the surgery day is concerned, because you have the added cost of the cryoablation, but thereafter the cost significantly reduced. They also took into account the narcotic used, which was significantly better in the post-operative period for the patients with the rib stabilization and cryoablation. So in conclusion, they said like this rib stabilization with cryoablation is safe and does not increase overall hospital cost, with the added benefit of decreased hospital total length post-operatively and decreased narcotic consumption. There's another similar study by Jeff Choi et al. There are 18-year-old and above patients for a 1-year period in a level 1 trauma center, and they have like a similar sort of variables where they took into account post rib fractures, length of stay, operative times, opioid requirements, and pain scores. And they assessed long-term outcomes who underwent rib fracture with cryo. That 34 patients who underwent rib stabilization, 20 patients had rib stabilization with cryo, and they concluded that this is also safe and feasible for patients undergoing stabilization, but they could not find any significant difference as far as pain score or opioid score was concerned. So again, we cannot say decisively that like it did make a difference from the previous study by Bowman and Paul. There's another study. These are recent studies in 22 in-hospital outcomes of intercostal nerve cryo ablation and surgical stabilization of rib fractures, and it also involves like 18 years or older. With the rib fractures, stabilization, and without cryo ablation. Outcomes, as you mentioned, like they looked at total morphine consumption, and then the secondary outcome was like ICU length of stay, hospital length of stay, incidence of pneumonia, and the tracheostomy rate and discharge dispositions. And what they found was that there was a shorter intensive unit stay. There was a lower consumption of total morphine use, higher likelihood of home discharge, and lower rate of intubation and tracheostomy formation.
2 minutes, please.
So this is again to conclude, like this is a relatively new procedure. The amount of literature is still pretty scant, and most of the literature is from thoracic literature and mass procedures, pediatric procedures. But we can cite the literature from Bowman et al., which significantly mentioned about overall shortened hospital length of stay, decreased narcotic use, and cost benefits in patients who have rib stabilization with cryoablation. So again, like this is some of the limitations that we need to work towards in future. No standardized rib stabilization with cryo indications or randomized controlled study done yet. Efficacy requires prospective controlled evaluation. Most of the studies, as I mentioned, are like single center based, single surgeon based, and so it has like a lot of limitations. And we need more numbers. There's no studies comparing the extrathoracic or the intrathoracic path using VATS and whether there is a difference in pain. As far as I'm concerned, like I have so far had no bad results as far as extrathoracic ones are concerned. And I do follow up with them, and I do have a CT scan on 84th day because the studies have shown that like the screws that we use are incorporated during this time, and you can get a proper view of the cage, rib cage during this time. So long-term outcomes with this rib stabilization did not comprise of standardized pain or quality of life questionnaires. So we need to work on those, like McGill spent a questionnaire, trauma-specific quality of life survey in future to have a better discussion about like whether these are beneficial or not. It's still in its infancy, still works to be done. Thank you.
Nice talk about this. Because of time constraint, we are going to wrap up right now. And thanks again, all the esteemed speakers for coming and sharing your experience and expertise. And this concludes our 84th annual clinical trauma session. Thank you very much.
Excuse me. Excuse me.
Here, like it stays, control stays for
Friend, how are you? Well, how are you? Good. Good. I saw your booth earlier. How are you? Yeah, I know. I wasn't Yeah, just started in my friend, how are you? Excellent. See you. All right, thank you. In Czech and in English. Okay, well, I think English for sure. Thank you very much. How do you say first name? Jerry?
Second year on my agenda. It's going to show someone. I just do the pictures. Yep. A bunch of slides that were hidden. Here first. Yeah. Yeah, see? That's yours, right? Pardon me? Yep. Okay.
It's 10:17, so we'll get started. I'd like to welcome everyone to our session on rural surgery. So critical access hospitals in the rural United States and globally have limited resources, which can pose significant challenges to the provision of care. This session will focus on the adaptation of techniques and practices for the treatment of rural patients in limited resource settings.
Our first talk, Harness-Hang syndrome, is given by Dr. Shabsigh, and I sincerely apologize if I just butchered that, from Myrtle Beach, South Carolina, the Associate Program Director of General Surgery Residency, Director of Surgical Research and Stimulation at Grand Strand Medical Center. Did I say that so wrong?
It's right.
Okay.
So it's a change of topics, jumping from replating to suspension syndrome. This is something which is very rarely reported because a lot of people don't know about suspension syndrome and the harness-hang syndrome, which is like synonymous with it. Different names comes with it. Usually involves people who are hanging with a thread or with a rope or anything, people who are doing construction work at a height, people who are into sports jumping, or cave exploration and stuff like that, and they are like held motionless in a particular position for a long period of time, they develop syncopal or presyncopal symptoms, and that can eventually even lead to death. So without any trauma. And so this is an unusual one. I was giving a talk sometime a couple of years back on hanging and near hanging. And as I was researching for my presentation, I came across this suspension syndrome, and I got interested in that, and eventually found out there's like lots of literature which has been, especially in the field of wilderness medicine and stuff like that. I have no disclosure. So suspension trauma syndrome was first described in a report of autopsies in people who died suspended from a harness in Austria and Spain. This was reported in a wilderness conference in 1970, and there was probably 10 people who were involved in this sports activity in the Alps or somewhere, and they all died. They did not die together, but they did die. Some of them were in the hospital after a week or so. Some of them died within the next few hours. But they eventually, all of them died, and none of them had any documented trauma that was recorded. So minimal traumatic injuries concluded that the cause of death was some sort of a shock. They were still not sure what exactly was the shock from, but there was some sort of shock which was involved in that. And so the suspension trauma syndrome, also known as harness hang syndrome, because there have been incidences where the harness that has been involved in people who are butting windows at a height, or working with high-rise construction, working with tall bridges and stuff like that, they do have the potential of developing those syndromes. And it's defined as development of presyncopal symptoms, loss of consciousness of the human body, if it's held in a motionless position, in a vertical position for some time. So this is some of the predisposing factors. None of them are absolute, but those are the ones which have been cited over and over. And there is a 2006 Occupational Safety and Health Administration, OSHA guideline, which is taken into account multiple times by different organizations all over the world. And they mentioned about if you're suspended for more than 30 minutes, it increases your risk of the suspension syndrome. Although, as it says, it's very unpredictable. Different people have different numbers for that, depending on the age and stuff. Height, 5 feet or more is documented as the height. Age and gender. Gender doesn't have any effect that is documented. Older you get, the poorer the cardiac reserves and the arterial functions, and those are more vulnerable. Weight, increased weight has shown to have been a risk factor. So these are some of the harnesses. I have some pictures of the harnesses at the end of my slides. So these are chest harnesses, which are, again, can be from different types. The dorsal harnesses, which have been mostly studied because those are the ones which are like a strap in the back and then with a strap in the front, in the chest. And then the seat type positioning, those are the ones where you clean the windows or paint height or something like that, and full body harnesses. They have their modifications for safety reasons and stuff. I have pictures later on which I can discuss on those. So discussing about the types of harnesses, because the types of harnesses determine to some extent the injury types and the risk of the suspension syndrome. So the dorsal harnesses, which is again mostly it's the harness which is in the back, and then like straps in the front over the chest wall, and then one along the inguinal region, which is holding your body up. And there's decrease the blood flow, creating functional hypovolemia by limiting the physiological movement of the rib cage and the diaphragm. So this decreases the respiratory volume and then increases the interthoracic pressure and then decrease in preload and cardiac activity, cardiac output. And all this help in producing the suspension syndrome and presyncopal episodes and stuff. So Beverly et al. Increased frequency with dorsal harnesses, the increased frequency of death, increased frequency of suspension syndrome with this type of harness specifically. And they did a prospective randomized study of differences according to the type of harnesses. They used frontal harnesses, dorsal harnesses, and a full body harnesses. And they found out that the full body harnesses was the best tolerated. So again, the dorsal harnesses increases the heart rate. There was noted to be a compensatory autonomic response to the decrease in pulse pressure and heart volume. This decrease in pulse pressure, when associated with the presence of dizziness, that eventually happens in these people who are hanging motionless for some time, is an indication for onset of poor cerebral perfusion. From then onwards, it's a pretty significant downhill road for all these people. Frontal harnesses, no significant change in heart rate was identified. On the other hand, the assessment of the map showed an increase rather than like a decrease in the previous one, and seeing a clear decrease in the pulse pressure. So there have like been cases where the dorsal harness group, there's an increase in AST seen in the plasma. And the explanation that was given was the compressive effects of the groin straps that is holding the person in place in a hanging position. That causes muscular ischemia at that site, and that can cause a rise in AST. So controversies were significant. We've come up with different opinions, different hypotheses, still not there yet as far as like pinpointing that like what is the causative reason for this suspension syndrome. One of these hypotheses is the sequestration of blood in the lower extremities with pooling of blood by a deficient muscular pump causing low cardiac output. And this was like for a long period of time considered to be the only explanation. Now there's different theories which come up. Second theory talks about metabolic waste accumulation and hyperkalemia that can cause anaerobic muscular metabolism and then eventually has its own detrimental effects from there. Another theory is that harnesses with a dorsal hook may be a trigger to postural asphyxia and vascular compression of arteries and femoral veins exerted by the harness in the inguinal region, causing a decrease in venous return as opposed to the ventral hook harnesses in which the effect is less severe. So this is like a schematic diagram which takes into account like some of the hypotheses I mentioned. Like here you can see like there's pooling of blood in the lower extremities, so there is like a compromise of the cardiac output, decrease in preload, and eventually the patient loses diminished blood supply to the brain. The patient loses consciousness, and his head hangs over, the airway is blocked, the tongue falls backwards, and you end up with a respiratory death. So if unconscious, release the harness as soon as possible. So the title of my talk was about the myths, about the evidences. So this was one of the significant myths. In fact, like I've been to some of the EMS conferences and talking to some of the senior EMS personalities. They did mention about the semi-Fowler position, and so they believed in that semi-Fowler position. And for a long period of time, this was considered like the way to treat suspension syndrome. And what they recommend is that like soon after you put the patient down from a harness, you put the patient in a semi-Fowler position by keeping his torso in an elevated position, approximately 30 to 40 degree angle, and slowly moving to a supine position in a period between 30 and 45 minutes. Controversy regarding the initial management, since the lack of oxygenated blood received by the blood during the suspension period is potentially lethal. Now there are certain groups that says even riskier in place that patients in the supine position immediately after the rescue has been done due to the reflux cause death by producing an acute overload of blood into the right ventricle by massive return of blood. So the right ventricle is overloaded with blood, and that can cause significant overload effects and death from reflux. So they are the ones who are proponent of the semi-Fowler position. But in a study of 10 volunteers who maintained suspended by a harness until they showed signs of circulatory collapse and immediately placed horizontally, it was identified that they did show sinus arrhythmia and ventricular systoles. And all this did show that the rapid venous return accumulated blood could produce cardiac failure and death. However, presently the paradigm has shifted, and we are going more towards the ATLS protocol. But on the contrary, the paper by Weill contradicted the theory of this reflux death syndrome, and they did the pathophysiology of the reperfusion syndrome in skeletal muscles, which causes ischemia, and this says that as the ischemia progresses, less and less blood flow increases the edema and increases the effect of the ischemia and eventually necrosis. So their postulation was early restoration of blood circulation limits the additional loss of volume in the interstitium by reducing the edema. So the authors suggested that the patient should be released from the harness and placed supine as soon as possible to restore oxygenated blood to the damaged muscle. Maintaining this vertical position in these patients or a semi-fowler position in these patients will simply worsen the muscle damage and hypovolemic shock. So the patient ideally should be transferred to a hospital and should be followed with the guidelines for ATLS. This is like a quick cartoon about the management protocol. If there's a rapid descent possible, obviously the patient is conscious or unconscious, they will call for help. Make sure that the patient can be transferred to a trauma center, ideally with a dialysis facility, because a lot of these patients develop renal failure and may require dialysis long-term. And or if the patient is not capable of having a recent rapid descent, then obviously a call for help, and that needs to be arranged. If the patient is conscious, then like there are different types of adjuncts to the harnesses that has been added now commercially, which can move your legs so that like you have harnesses, you have the harnesses in the strap in the chest, in the groin region, and you have an adjunct which can you can buckle into your foot, and then you can keep moving your legs so that like you do not lie motionless in a vertical position, and that can help also in the outcomes. If the patient leg movements, as I said, like is significant, and that can improve the outcome of this patient. If the patient is unconscious, obviously, as far as the patients are concerned, the patient is a significant risk for death or anaphylaxis brain injury, so that needs to be transferred as soon as possible. So the management protocol is more or less the same. We normally follow the ATLS protocol, starting with primary survey, secondary survey, as in any trauma facility. Start with ABCDE, and then make sure that the patient doesn't have any trauma to supplement to this suspension. And then like start with hydration, make sure that the patient is adequately resuscitated with crystalloids initially. As I said, like some of them develop renal failure. In fact, like quite a significant number developed renal failure, so that needs to be resuscitated adequately. They can be hypoglycemic during this time, so hypoglycemia should be corrected. They have electrolyte disbalance, which should be corrected aggressively. Care should be taken to replacing potassium aggressively, because they can have hyperkalemia, and so unnecessary aggressive replacement can cause a detrimental effect. Obviously, pain relief, because that adds to the stress and anxiety and all adds to the problem. Important to do EKG, because that will show peak T waves for the hyperkalemia, QT prolongation, Weill and QRSS complexes, those to be medically managed. BP should be monitored very closely, because high BP can indicate hyperkalemia. We need to look into the CMP, BMP, and correct it adequately. Again, as I said, should be immediately transferred to a trauma center with adequate facilities, probably with dialysis facilities. Rhabdomyolysis is a complication, is a known complication, and most of these patients do develop renal failure as a complication. So you need to monitor them and adequately manage rhabdomyolysis with volume resuscitation and monitoring myoglobin and CK. So this is the study from the Wilderness and Environment Medicine Journal, which brought more clarity to the suspension syndrome. So the date was, the authors examined widespread belief that the blood pools in the legs when an individual is passively suspended. So what they did was like, they did study on the superficial femoral vein, which is like technically a deep vein. And ultrasound studies were done on the distension of the superficial femoral vein. And while study participants were passively suspended, the vein returned to normal once the participants were lying down. In normal circumstances, the muscle contractions of the legs squeeze blood upwards past the one-way valve back to the heart. So their studies confirmed that widely held hypothesis that moving the legs could restore circulation of this pooled blood. The ultrasound studies showed that stasis of blood in the vein while participants were passively suspended, followed by rapid resumption of venous flow while movement. So this contradicts the Fowler position, that like it should be in a semi-Fowler position before your leg supine. So this says that like there is a rapid restoration of blood flow soon after and without any significant detrimental effects. So the true incidence of suspension syndrome is unknown and it's rare. This study is consistent with other studies suggest that 30% of the climbers and others suspended on rope are at risk. So some other studies which again debunk the persistent myths. One of the myths again, as I said, rapid venous return after lying the victim flat could overload the right side of the heart, causing immediate rescue death. So there have been echoes done on those heart, showing that like the heart shrunk going to the venous pooling, returned to the original size after the rescue without any additional enlargement. This notion of fainting while suspended passively on the rope was due to insufficient cardiac preload owing to the sequestration of blood in the legs and possibly from a basalt gyrus reflex was probably not right. And we need to look into that. And then this echocardiography on those subjects confirmed that the cardiac preload remained adequate soon after they were put back in supine position. So instead, they opined or they postulated that this was a syncopal episode where it was a neurally mediated phenomenon and it happened with one of the triggers being the orthostatic position of the patient. Some of the other myths that have been put forward, that femoral arteries and femoral veins are the causative organism, causative agents for harness pathology or harness hang syndrome. And this, so it's now clear that based on the ultrasound imagery that the femoral veins and femoral arteries are not affected by sit harnesses, and passive suspension is the problem rather than compression of the vessels by the harness. So harness management should not delay rescue. It should in fact be one of the first priorities. Passive suspension should be taken seriously. And one of the things that we mentioned, the patient, the person, if it's able to, should keep moving their legs while awaiting rescue. Victims of syncope due to suspension should be placed flat immediately after execution, and ATLS management protocol should be followed. So these are some of the pictures I was talking about. The first one is one where it's a sit type, and these are like some of the ones where you are like holding your chest. These are dorsal harnesses with a chest strap, and some of them with a groin strap. There's the ones like which can cause restrictions in blood flow if you're holding in a motionless position. And those are some of the adjuncts I've mentioned, where you can put it into your foot and move your foot so that like you're not lying in a vertical motionless position. Thank you.
We will have to do questions at the end. We went over a little bit. Okay. Thank you so much. So our next speaker is Dr. Buckley from Austin, Texas. I personally asked him to give this talk because practicing in a rural area, a lot of times we end up being the GI doctors, and one of the most common things we deal with is GERD. And so I asked him to give this talk, an update on GERD, the ACG guidelines, medical and surgical treatment. He is the Associate Professor of Surgery from the University of Texas, Dell Medical School.
Thank you, thank you for the kind invitation. I really appreciate it. I don't know that I've given a 15-minute talk in a while, but I will try and stay on time. Just jump right into it. So, GERD therapy is now 2023. Primarily medical, right? But PPIs don't do everything, and they can't do everything. And so we know from the GI literature that about 30 to 40% of patients have symptoms on PPIs, so breakthrough symptoms, etc. They're unhappy. And really, surgical therapy represents less than 1% of what we do, despite the fact that there are 18 million Americans out there that probably could benefit from anti-reflux surgery today. So we're going to delve a little bit into why that might be. These are my disclosures. So what is GERD? Obviously, it's just reflux of gastric juice into the esophagus. It's largely a mechanical problem, despite the fact that we use PPIs to treat it. And what are the causes of GERD? And so because it's a mechanical failure, we look at the crural diaphragm, so you can have a hiatal hernia. That's going to put the lower esophageal sphincter in the chest, which is a negative pressure zone. We learned a lot about the chest this morning. We have the flap valve, or the angle of His, that prevents reflux ache. And then you have the sphincter itself, which is really the sling fibers. And so our goals of anti-reflux surgery are to restore normal anatomy. So you can see the endoscopic view of what the flap valve looks like. And if you're in a rural setting and doing a lot of EGDs, this is kind of what you're looking at. That's a pretty competent valve. This would be obviously an incompetent valve. So looking at a small hiatal hernia, you can see the rugal folds going up into the chest, and this is going to be a problem for that patient. So how do we start to evaluate patients? And I think that whether in a rural setting or in an academic center like myself at Dell Medical School in downtown Austin, where I've got all the neat things to do, we can still do good evaluations everywhere. So the